This video is going to be on schizophrenia. Now, schizo means split, phrenia means brain, and so the characteristic defining feature of schizophrenia is a split, a division between what you perceive as reality and what is actually reality. So I'll write split between perception and reality. There are many symptoms that will show up when you have this split, and we can divide that into positive and negative symptoms. Recall, positive and negative in the psychiatric term does not mean good or bad. It means a net gain or a net loss of something. Okay, so we'll talk about positive first. These are things that weren't initially there, and so you're gaining something. Yeah, that's a net gain, that's positive. These include things like delusions. These are firm belief in something that can't be refuted. Even if they give you all this evidence, you're just like, no, I believe this, I believe this, I believe this. That's delusion. You can have hallucination. That's perceiving something that isn't there. You can have disorganized speech and behavior, so talking in a way or behaving in a way that wasn't there initially. And as they fall deeper and deeper into their delusions, they start to become withdrawn. They start to lose. So now we're talking about negative symptoms because they're losing something, net loss. They start to lose social communication skills. They stop talking to people. They'll start to lose motivation, start to lose all these things. They become very withdrawn, very sullen. Okay, so I'll just write negative symptoms, but you should just know that it refers to things like loss of speech, and I'll just write sociability, loss of motivation. That's a lot of symptoms. What is the diagnostic criteria? Everything needs a diagnostic criteria. We can't just list symptoms. So the diagnostic criteria is you need at least 2 of these, at least 2, with at least one of the following being delusion, hallucinations, disorganized speech. At least 1. And that is the symptoms. And if you're thinking, well, what's the time frame? Then hallelujah, I've finally made it through to you. So high five through the screen. Always know the time frame. This one's no different. What's the time frame? You have to have at least 2 of these symptoms, with at least one of them being this, for more than 6 months. You might be thinking, well, what if it's less than 6 months? If it's less than 1 month, we call that acute psychotic disorder. Acute because it's acute. Psychosis just means these symptoms. Yeah. Because it doesn't fit into the criteria of schizophrenia, we can't call it acute schizophrenia, so we just call it acute psychotic disorder or acute psychosis. How about 1 to 6 months? Well, they're really getting into the specifics here, aren't they? This is schizophreniform disorder. Schizophreniform disorder. That's how important time frame is, down to the months. 1 to 6 months. Golly. Okay, so know this well. There are different kind of subtypes of schizophrenia that I think you should be aware of also. You can have schizophrenia with mood disorder. So schizophrenia with mood disorder. Mood disorders we call as things like elevation, depression, and mood. So we talked about major depression, and we also talked about bipolar disorder. If you have mood disorders and you have psychotic symptoms while you're having those mood disorders, and only when you have those mood disorders, and if those mood disorders go away, if that depression goes away and the psychosis ends, we call that depression with psychosis, or just psychotic depression. So emphasis on depression. Yeah, the psychosis is just along for the ride. However, if you have mood disorders with psychotic symptoms again, and the mood disorders, when it goes away, the psychotic symptoms are still there, still present. That's not the same thing, is it? We call that schizoaffective disorder. Affective, affect meaning your mood, schizo meaning schizophrenia. So here the emphasis is on schizo. The emphasis is on the psychosis that's still present even when the mood has gone away. So alright, psychotic symptoms still present. Even when mood disorders are gone. Seen in a couple questions, I'll talk about someone that has that needs to be hospitalized because they're manic, yeah, so that's bipolar, and they're having these psychotic symptoms, and after they stabilize them and that manic episode goes away, that psychosis is still there. Or they might say they had a history of psychosis and it's still there even without the mood disorder. That's schizoaffective disorder. Last thing I want to talk about is delusional disorder. Delusional disorder is when you have delusions. So that's that fixed, firm beliefs. What's the difference between this and everything else? Doesn't have anything else. It just only has delusions. So a patient will have that firm delusions, won't have hallucinations, won't have disorganized speech behavior, usually lives a normal life. They just have that fixed delusion that can't be changed no matter what. That's delusional disorder. And oftentimes their partner gets dragged along for the ride. They spend so much time with their partner and basically tells them all these delusions that the partner may have this delusion also. That's delusional disorder. Now I just want to take a second to talk about hallucinations coming from other sources. If a patient comes in and has hallucinations and the first thing you think of is schizophrenia, then think again. It's more commonly due to some other source, more commonly due to drugs. Yeah, so you might want to do a drug screen on them first. Let's talk about hallucinations. So hallucinations are broken into all the different senses. So you can have visual hallucinations. Visual. These more commonly come from drugs like LSD, mushrooms. You can have tactile. Seen in cocaine use, you can also see it in withdrawals of alcohol. The common way to describe it is feeling like they have ants crawling all over your skin. You can have olfactory, that's smell. Seen in temporal lobe epilepsy. They say it smells like burning rubber. All right, rubber. You can have hypnagogic, hypnopompic. These are hallucinations you see right before you go to sleep or right after waking, and it's seen in narcolepsy. And actually is not as concerning as it sounds. It might sound really freaky right before you go to sleep. You like feel something or you see something, but it's common in narcolepsy. So it's not, you're not thinking things like schizophrenia. One thing we didn't talk about, one sense that we didn't talk about is your hearing, auditory. Now we're cooking. Auditory is more seen in psychiatric disorders. And in fact, it's the most common hallucination subtype that we see in schizophrenia. So I just wanted to clear the air, make sure you understand that not all hallucinations are from schizophrenia. Now what's the epidemiology of schizophrenia? It's been up to debate. The way I've been taught it and the way it's been taught for a very long time is that it's equal among everybody. So every socioeconomic group, every cultural group, equal in men and women. But that's still up to debate now, so I will put in my notes what I've learned, but always consult whatever latest book you're using, okay? And then some risk factors, genetic factors. Substance use are pretty established. Something that's up to debate is whether or not cannabis use can cause it. So, all right, cannabis? A lot of question marks. But other substance use like LSD and genetic factors play a role. So it's multifactorial. All right, let's erase this cannabis question mark. That kind of sounds dumb. Now let's talk about the proposed mechanism of schizophrenia. When we scan the brain, we see things like atrophy, we see ventriculomegaly. That's when your ventricles enlarge. So that's grossly what we see, but what's going down microscopically? What's going down in the neurons? A lot of theories of psychiatric disorders have to deal with fluctuations in neurotransmitters. Could this also be caused by fluctuation in neurotransmitters? We've noticed that if we give drugs that increase dopamine, like L-Dopa, then it can precipitate signs of schizophrenia. So, oh, that's something we can work with here. So increased dopamine in the dopamine pathways seem to precipitate psychotic symptoms or schizophrenia. So dopamine is used in a ton of pathways. A lot of pathways we learn together. Can you remind me what some of these pathways are? Hopefully you didn't forget. These will be things like your nigrostriatal, which connects your substantia nigra to your striatum and needed for movement. Recall that's what we think causes Parkinson's. Decreased dopamine in this pathway can cause movement disorders. All right, Parkinson's. How about your tuberoinfundibular? This connects your hypothalamus and your pituitary. Your pituitary releases a ton of hormones. What's the role of dopamine here? What does dopamine do in your pituitary? Hopefully you remember. Dopamine blocks prolactin, keeps it in check. Okay? And we notice that if you have decreased dopamine, then you won't be able to block prolactin. You have prolactinemia. Prolactinemia. That's never good. Those are things like galactorrhea, so breast milk, gynecomastia, amenorrhea, loss of libido. Those are never good. So prolactinemia is never a good thing. Those are the ones we talked about, but that's not the name of the game today. Let's talk about the pathways that we think is associated with schizophrenia. These would be your mesocortical, mesolimbic. The meso part is your midbrain. Your midbrain is highly associated with processing stimuli, visual, hearing, movement. And that connects to your cortical, your cortex, or your limbic system. So when there's some sort of change or disruption in that circuitry, then we can have schizophrenia. When there's some sort of influx of neurotransmitter, when there's maybe too much dopamine, we can have a problem in our mesocortical or our mesolimbic system. And that is a proposed mechanism of schizophrenia. What do you think we're going to do pharmaceutically to help schizophrenia? If it's due to too much dopamine, we're going to have to try and block dopamine. Okay? So we can give drugs that block dopamine, and those are called antipsychotics. Our first attempt, we'll just call our first generation. And these are called typical because they block dopamine outright. That's our pathway, our typical pathway. Can you imagine the side effects of this drug if we block dopamine? What happens if dopamine is decreased here? You're gonna have movement disorder. So initially in the first couple of days, you might have dystonia, really sustained contraction. You might have restlessness and pseudo-Parkinson's a little bit later on. And then after a while, you might develop tardive dyskinesia, where a lot of times you have like tongue darting out. So all these movement disorders, kind of like Parkinson's, because you have decreased dopamine. How do we want to alleviate this? Well, we can alleviate this by giving a drug called benztropine. Benztropine is an anticholinergic that blocks acetylcholine in the synapse, kind of lowers neuronal firing, and also increases dopamine. Kind of helps alleviate that. Now let's move down over here. What happens if we block dopamine over here? Recall, dopamine inhibits prolactin, so if we block dopamine, we'll have prolactinemia, all those signs. Now, we don't want those signs, so what are some drugs we can give to kind of alleviate this? We can give dopamine agonist, kind of raise that dopamine back up. These are going to be your bromocriptines, your cabergoline. You hopefully recall that from your endocrine block, the bromocriptine. And that, again, just helps alleviate. But this is where the money is, blocking dopamine in these pathways, and that's how they work as antipsychotics. But these came with just so many side effects. I mean, we talked about some side effects here. We haven't even scratched the surface. Let's talk about a little bit more. You can have something called neuroleptic malignant syndrome. The heck is that? Neuroleptic means a neuronal blockade. You're blocking something. Any drug that blocks something in the neurons can cause really adverse effects. Here, in antipsychotics, it can cause neuroleptic malignant syndrome. Blocking dopamine, they propose, increases glutamate, decreases GABA, also increases calcium release from your sarcoplasmic reticulum, causing muscle contraction. So you have this really strong muscle contraction from all that calcium. You have all this glutamate that can cause neurotoxicity, so neurotoxicity. And that is just bad news bears. So the sustained muscle contractions, you can have things like hyperthermia, increase creatinine. The neurotoxicity can cause autonomic instability. So things like hypotension. The way they ask this question is they'll talk about someone that has psychosis or had all the signs of schizophrenia and then was given a drug and then suddenly came in to the ER just rigid as all get out. Rigid, hyperthermic, they'll give you the vitals, they're hypotensive, just looking in terrible shape. This is neuroleptic malignant syndrome. How do you treat it? You're gonna give dopamine agonists. Try and raise that dopamine. So things like bromocriptine, dopamine, and you're gonna give something called dantrolene. What the heck is dantrolene? Dantrolene stops your sarcoplasmic reticulum from releasing calcium by binding ryanodine receptors. That way you stop the muscle contraction. So that's a nasty side effect. And unfortunately, we're not even done yet. So some general side effects. We realize that these anti-psychotics weren't very specific to the dopamine receptors. It can work on histamine receptors. Blocking that causes things like drowsiness, so sedation, causes weight gain. It can block your alpha-1 receptors. That causes vasoconstriction, so if you block it, you get vasodilation, you get hypotension. Then muscarinic receptors, you get things like dry mouth, blurry vision, urinary retention, constipation, all that bad stuff. All that bad stuff. That is your side effects. Let's talk about our particular drugs. Our particular drugs can be broken into high potency and low potency, and that's important because low potency drugs don't work on dopamine receptors as well. That's why they're called low potency. However, they seem to work on these well, and that's not a good thing. So all right, low potency drugs are less associated with the dopamine side effects, so things like movement disorders, things like hyperprolactemia, so less dopamine side effects, but more H1 and alpha-1 muscarinic side effects. These drugs include things like chlorpromazine and thioridazine. Chlorpromazine causes corneal deposits. Thio can prolong your QT interval and cause retinal deposits. Deposits actually in your retina, and that can cause blindness. That's your low potency drugs. How about your high potency drugs? Well, your high potency drugs work on dopamine receptors, that's why they're high potency, and work a little bit less on these receptors. So they're going to be more associated with dopamine side effects. So things like movement disorder, things like hyperprolactemia, and less associated with these side effects. So H1 side effects like sedation, weight gain, A1 side effects like hypotension, muscarinic side effects, so decreased association with those. The big one, haloperidol, can be given as an intramuscular injection, high potency, so if someone comes in acutely psychotic, you can first off strap them in and then give that haloperidol. All right, so those were your first gen antipsychotics. That was like our first run at it. And it turned out the side effect profiles just weren't very good. But people said, well, what do you want from us? What do you expect from us? We only have one pathway to work with, yeah, and that's what causes all these side effects. And then someone realized down the road that if you give LSD, it can cause signs that look very similar to psychosis. LSD works on your serotonin pathway, And that's important because now we have something else we can work with. What does serotonin do? Serotonin does a lot of different things in a lot of different places, but for your intents and purposes, you need to know that serotonin inhibits dopamine release. Serotonin inhibits dopamine release. So you have all these serotonin containing neurons. They release serotonin, and that inhibits dopamine release. So now we have a new pathway we can work with. So our friends in the pharmaceutical business looked at this pathway and said, what can we do? How can we manipulate it? We can give agonists or we can give antagonists. Well, let's try agonists. If we give agonists and we increase serotonin, that would further inhibit dopamine. That would lower dopamine. That's not really, a positive step in the right direction. That's what we did in our first gen drugs. We decreased dopamine and gave us horrible side effects. So that doesn't really help. How about an antagonist? What if we decrease serotonin? Decreased serotonin would increase dopamine. You no longer have that block. That's counterproductive. Increased dopamine is what caused schizophrenia in the first place. That doesn't really help. Until someone realized, wait a minute, you have all these serotonin receptors in the first two pathways, but very few in the schizophrenia pathway. Because you have so much serotonin receptors in these two pathways, and dopamine will increase greatly. But here, where it matters the most, because you don't have a lot of serotonin receptors, these serotonin drugs wouldn't work, and dopamine would remain blocked, and dopamine would remain low. And then they said, oh my God, you're a genius. And they popped champagne and they partied for like 10 days straight. I'm like 80% sure that's how it went down, okay? So that is our second gen antipsychotics. Those antipsychotics work on our serotonin pathway. By blocking serotonin, we're able to increase dopamine where we need it and keep dopamine low where we want to. That is your second gen drugs. And they're commonly called atypical. They're atypical because they don't work on the normal dopamine pathway. They work kind of indirectly on the serotonin pathway. Very important because these drugs have a much better side effect profile and now are first line drugs. So all right, better side effect profile. Now that that's said, let's look at some side effects. No drugs without side effects, and certain drugs cause very, very rare side effects, but side effects that you do need to know. Okay? The first one is clozapine. Clozapine really affects your blood, so it can cause agranulocytosis, or basically a lack of granulocytes or a lack of white blood cells. So you need to constantly monitor white blood cells. All right, monitor white blood cells. It can also cause myocarditis. That's no good. And it lowers your seizure threshold. Next up is olanzapine. Olanzapine works on H1 receptors a little bit too much. If you recall that, it causes things like sedation, also causes weight gain. So olanzapine has the highest incidence of weight gain. And just things like metabolic syndrome. Risperidone also didn't get the message. So risperidone was one of our first drugs to come out, or first second-gen drugs to come out, and is known for causing hyperprolactinemia. So I guess it doesn't really work on this pathway as well as we hoped it would. You can have ziprasidone, which causes QT prolongation. And lastly, you can have quetiapine. Quiet, this kind of sounds like quiet. This is one of the more sedating drugs. And that is this big side effect. So hopefully I've really stressed the importance of knowing the side effects of these drugs. Common questions when it comes to schizophrenia is first diagnosing it correctly, so knowing the time frame, and then after you've diagnosed it and you're treating it, they'll give you a side effect and you have to kind of remember which drug it relates to. That does it for schizophrenia. Hope you enjoyed. See you next time.